Hello, everyone. Today, we want to talk about some nursing advocacy, nursing leadership, and we're going to also talk about professionalism. So for the first one, I would like to start off with advocacy. As you guys are actually getting ready to do or are doing your advocacy presentations for class, and so I wanted to go ahead and do that first. Please remember that is your role. It started out with Florence Nightingale. She and some military models helped pull nursing in to advocating for the patients, because of course we all know that Florence was the biggest advocate, especially for all of the poor gentlemen that were being killed by the filth rather than the actual injuries that they got in the Crimean War. There was a hierarchical issue for quite some time, showing or presenting that it should be the nurse's duty to obey physicians and maintain order in the hospital, and that we should unquestioningly be loyal to the doctors in the hospitals, even in the face of doing wrong. And I can tell you this became very, very uncomfortable. So as nursing was pursuing its own sense of professional identity, we started separating ourselves from physicians and institutions so that we were an entity of our own. Just like a hospital is their own entity, physicians are their own entity, so is nursing. Nursing actually is a profession, and we have a variety of things that we do that no one else in healthcare can or does do. So one of those is to advocate for the patient. That means that we are actually protecting and working for the patient's rights and interests to be respected, to be followed. So there's several models out there. I think we're going to talk about Bernal's here. We're going to talk about the Bernal method, how it actually recognizes that patients have the right and that we should no longer allow institutions or physicians to undermine those by their practices or unequal power structures. So we need to actually stand up and do that. So nurses actually have a duty to empower their patients, both directly by supporting patient autonomy and indirectly by working to change practices that actually disempower patients. So when I say that, I want you to think about what happens when you admit a patient. Well, the first thing that happens is you have them take all their clothes off, and then you take them away and you put them in a bag, including their shoes and socks and underwear. And then you put a band on them, and then you tell them, you stay in the bed, and here's a call light, and I will be back shortly. Well, that's not very dignified or even something that some patients consider as being advocated for. It's almost in a demeaning fashion. And that's because nurses actually followed the physician in the institutional manner. We need to change those. Now, don't get me wrong, we have changed quite a few of those. We no longer are, quote, handmaidens or servants to the physician. They now understand that we are a different profession. The Institute of Medicine and their recommendations and reports have actually helped build some of that understanding of how we are different. Then we need to make sure that we are making the best choices based on the patient's wishes and interests. So a couple of examples here. In a particular book, I'm not going to just say that a nurse was actually forced to follow an inconsistent order that was given regarding 2 patients about their resuscitation. It could have been the one where it was a DNR, but the doctor said, oh no, we're going to code them anyway, they're too young or whatever. Then of course we have Leah Curtin. The issue there was that the physician was actually not informing the patient regarding their diagnosis of cancer. The nurse took it upon herself to do so as being the patient's advocate. Now, let me tell you, that was a political nightmare, but it was the right thing to do. It was the right thing to do for our patients. So Bernal has a critique of advocacy. So it continues the old view of nurses as the guardians of morality. Okay? So yes, we are the guardian of morality, but we are also the only person who is knowledgeable enough in healthcare that we can actually provide that support to the patient that does not have a singular vested interest. Remember that nursing is all about prevention, right? You have to remember that institutions are all about hospitalizations, and physicians are all about curative. You don't see a physician, or he doesn't really do much of anything until something happens. And then he's going to give you a pill, or we're going to do this, we're going to do some other things. So that's part of why our healthcare system is so fragmented and actually does not work anymore. It is so expensive, but we actually deliver very challenging care, but we don't do it very well. There are people in other countries that do not have the technology that we have, but yet they have better outcomes because the focus is on preventing things, because they actually don't have the resources to be a curative system. And there's a huge difference in that. Some of the third world countries have really made some significant changes in that. Yes, we've helped them do that, but it's interesting that we're not able to help ourselves do that. So we need to portray nurses as adopting whatever values the patient supports and portrays, and what relationships between the patients and the professionals and the institutions. We actually don't want them to say that they are adversarial, or that we are, or that they're manipulative, or that we are, but we do know that there is a complex out there where physicians, quote, do no wrong, and everything they say is correct and factual and should be followed without question. And I can tell you that that is no longer accepted as truth. It used to be, but we now know that that is not truth. They are just as human as we are, and they are fallible just as we are. We have to be careful about neglecting important moral considerations besides patient autonomy. How about the appropriate or just distribution of resources? So if we have someone who actually wants to pass away, they're on a ventilator, and we have a need for another bed, and this patient has been asking, and the family, for days for a wean, extubation to wean, to terminal wean, that's what I'm looking for, extubate to terminal wean, but the physicians are not ready for that or accepting of that, so the order does not get written. And despite how much nurses will ask and beg and talk and portray, it takes a little while to go through the process. And the process I'm talking about is the ethics committee, who you would then pull that forward to the ethics committee and let them come in and deal with that. But the big problem is I have a patient down in the emergency room who needs that ventilator, who needs that bed, but yet because of the physician's inability to understand the patient's point of view and their rights of decision making, then we actually do not follow the patient's wishes. It becomes a problem. So why are we making this patient suffer and give those resources and make them take that resource when we actually have someone else who needs that resource and we could deliver it? So it's kind of an interesting thing. That's not a perfect example, but it is something for you to think about, because I have seen that happen as well. Finally, advocacy models need to make sure that they do not place too much focus on patient autonomy, because much of the patient's experience involves suffering and vulnerability, which requires the consideration of third-party interests, such as healthcare insurance, consulting physicians, those kinds of things. We do need to look at patient autonomy, but we need to look into it as part of the preventative healthcare, not the reactive healthcare. There is a huge learning curve for when we are going into the reactive part of medicine, which is why nursing is so in-depth now, much, much more than it used to be. But we do need to work more towards patient autonomy before we get into a medical issue, and that would be preventative. And that would be a great place for nursing to help advocate for patients. So the covenant model that Bernal recommends is that we focus on the patient-professional relationship. We look at the nursing profession's duties as a whole, and that as a profession, nurses are actually indebted to society for the training that they've gotten and the professional benefits that nurses receive from that, like being the #1 trusted profession in the country for many, many years. The only time it hasn't been in the last 20 years was in '91 for the 9/11. Because that happened just prior to the vote, fire rescue had it that time. And then the very next year, nurses went to the top again. So we have to make sure that we recognize that society is also indebted to the nurses because of the work that we do. Nursing is not a profession where you just go in and you do your job and you collect a paycheck and then you go home. Nursing actually has many components to it that are not physical, but they are emotional. They are supportive. They are spiritual. And you actually have to have specific arts that you're born with to be able to do a good job at this profession. So we have to make sure that that is also respected. That equals that there is a mutual indebtedness, okay? And we actually have an exchange of promises between nursing and patients. Nurses are actually given the freedom to practice by those that we care for, the patients. I mean, how many of you would go into somebody that you don't know? Now, I'm not talking about into a hospital or a doctor's office or something else. I'm just saying you walk in to a building and they say, take your clothes off, go get on this table, and put your stuff in this bag, and we'll be back in a few minutes. How many of you would feel comfortable doing that? Well, we've done that. We've actually trained patients that they do that. Now they think that's normal to go in and do that and make themselves vulnerable in a building that's not what they would consider a safe environment for a home. So when they give us that freedom to practice, they also make it very clear that there is a promise that nursing will remain faithful to the ideal of patient service. Advocacy is a part of your role. The duty to respond to the patient's preferred view of their relationship and even the wider variety of needs that sometimes illness and healthcare can put out there is just as important for that to be advocated for. That's a component of what you are going to be doing. You are going to advocate and educate your patient on what are the different options, what are the different priorities, those types of options. The covenant model is much more consistent with the goal of cooperation amongst all healthcare professionals so that we are a multidisciplinary and intercollaborative professional system. I didn't say a professional workforce. I said a professional system because all of us have licensures, significant education, and are given great control over people's lives. And we actually do need to have goal cooperation for all of us, and it should focus on the patient. So some of the things that you can consider as being started out as a nurse advocacy would be the American Disabilities Act, the ADA. That started out as a nursing issue. A nurse advocated for a patient that was not able to get in to see her physician because they were in a wheelchair and there was no elevator. There was no way for her to get in or anything else. And it was very, very difficult to get her in because people would have to carry her wheelchair up the stairs and then down the stairs. So that meant more than one person of her family had to come with her. And so it became very complicated. That one event, that one nurse, that one patient, that one family started that whole entire American with Disability Act. Now you see we actually have the act that supports that Americans have access to public areas, including physicians' offices, facilities where they go for and seek out help. That's just one example of how nursing advocacy has blossomed and made a huge significant piece for patients. Another one would be patients being able to determine their end-of-life requests. Now, the bad part of that is when they decided that this was going to be a DNR status or a not, nurses did not continue with what was going to be the patient's wishes for end-of-life care. The lawyers and the practice of law became involved, and now they have living wills. Some states will follow that living will, some states will not. So when the legal component came involved, it actually changed the advocating for a patient's right to die or the patient's will to have or deny health care. It's their right. It became skewed a little bit when legal stepped in because they saw, oh, this is a way that we could help involve, but they look at things very differently than nursing. We look at it as an art and a very caring, compassion thing, and they are 100% all about the legality and the politics. So I hope that this has helped you have a better understanding of the advocacy role that you have as a nurse. The next thing I want to talk about is leadership. Leadership is all about, sorry, I need to pull up my PowerPoint. It's all about how, as a nurse, are going to be a leader. Now, that doesn't mean that you're going to be the charge nurse. That doesn't mean that you're going to be the CEO. You can be a leader just by being an informal leader. And I hope that you understand what I mean by that. But so somebody who actually has a leadership title, meaning they are the CEO, meaning they are the house supervisor, meaning that they are the charge nurse. They have the title and the position as a nurse leader. So yes, they have to demonstrate appropriate leadership. There's lots of different kinds. But there's also those that are on the unit, on the hospitals, or in the homes, or in the companies that are generally the person that the others in that organization will go and seek out to ask questions of clarification. Where might I find this? How would you handle this? What would you do? Those are the informal leaders. And actually, those informal leaders sometimes have a bigger impact on an organization than is perceived by the organization itself. The American Nurses Association actually has a leadership standard. It's Standard 12. So we're actually talking about, uh-oh, it's not letting me do that. So let's talk about leadership. What is it? What is it? So it's our essence. It's the essence of how we act or we perform and provide direction or guidance. So like I said, the informal leader sometimes is more important than a formal leader because their influence is much more widespread sometimes. So it is all about influence. It is the process of influence. So the Institute of Medicine has called for us to have high-quality, patient-centered health care for all, okay? Now, this does require transformation of our healthcare system. We are in the process of trying to do that, but we have the Republican and the Democrat and the Independents who all have different points of view on how this transformation should occur and how we should reach it. So right now, the Democrats were in place. They voted in and instituted the American Affordable Care Act, and now the Republicans are coming into strength of influence, and so they want to change some things. But things have to be done differently since we already have a process. So we have so many more people who are already insured that were not insured prior to this, that it would be very important that we consider what kind of impacts that would be. There is a link so that goes to this TED.com. It's actually a pretty good video talking about everyday leadership. But Jim Kuza says that leadership is actually an art, a performing art, and an instrument of self. The mastery of that art of leadership comes from the mastery of self. So that means you have to master yourself before you can lead others. Okay? Some qualities of leadership, responsibility, right? Every single RN is responsible to be a leader, because you do have power, but you need to encourage empowerment of your patient. Now, leadership strategies are where we actually pay attention to what's the vision, where do we want to go, what is the ultimate that we want to reach, what's the outcome we want, and make sure that our communication is actually meaningful and effective. We need to make sure that positioning, that people are trusting, that we don't let them down for trusting us. And then, of course, you must talk about putting yourself out there and stepping up and becoming a voice for your patient. That doesn't mean you have to do it every day. Most of the time you will, though. You'll just do it out of habit. But it also means there are some nurses who have actually become even more political, where they have gotten involved in state and federal legislature on the behalf of patients across the nation and healthcare across the nation. So when we're looking at vision, leadership's the capacity to create that vision, then also translate that into, okay, how are we going to get that? So this is the vision, this is how we're going to get there, and then this is how we're going to keep it going. That's the vision, okay? So leaders that have that vision, others believe in them and treat them as they are very intelligent, so they recognize them as a leader, formal or not, and then people take on that vision and treat it as if it was its own. So that's really how vision can impact someone being able to be a leader. Communication. So this relies on quite a bit of things. It requires people to pay attention to body language, the written word, the verbal word. We need to look at sarcasm. We need to look at drawings. We need to look at any metaphors. We also need to look at emotions, both who's presenting and how they're emotional, and who is receiving and how their emotions are being involved. And then, of course, trust, optimism, and hope all are kind of like packed up in there. Because people in general have a base of optimism and hope, which is why we have such a hard problem with the increasing numbers of depression that we have in the world these days. And so some of that can actually be the way we communicate things sometimes. So we actually have to try to be mindful, and we actually have to make our communication mindful. Make sure you know what you're saying, why you're saying it. You need to prevent any of your personal biases or assumptions being put out there while you're communicating. You need to evaluate your stress level or the stress level of the other person. You need to be intent on understanding and not judging someone. We've talked about active listening before. This is extremely important. You need to listen to what they're saying first before you start saying something about what you think they need to do, before you've even listened to the whole story. So active listening, and then even listening empathetically, not sympathetically, but empathetically. Understand where they're coming from. You may or may not be able to do anything about it, but you still need to understand where that person is coming from. And then effective communication strategies. You actually already have some of those when you went into communication, and also when you went into community health, you used those communication strategies. So you're going to be using some more of those. I will tell you the communication piece is extremely difficult of leadership, because so many people do have their own personal viewpoints, and a lot of what they grew up with is what they believe in, and they do put that forward in what they communicate. The other thing is your stress level and the person who's receiving the information stress level, that can actually trigger lateral violence, actual bullying, quite a few things that we really prefer not to have. So communication is a very significant component of the leadership that we're talking about. So one of the things that we talked about was trust. So trust is the emotional glue that binds the leader and the follower, binds the patient and the nurse, okay? But that means the leaders have to be consistent. They have to follow through, just like a parent. If you do what you say you're going to do for any kind of consequences, then they're going to believe you the next time. If you never follow up on any kind of consequences that you say is going to happen if this occurs, then they know that it doesn't matter. You're really not going to do that. And so the trust goes away. So Studer Group is an organization that has helped the American Nurses Association and the American Association of Critical Care Nurses to bring leadership and advocacy and the reduction of lateral violence being from physicians towards nurses, and now we're using it nurses to nurses, and they've been extremely helpful in that. So what works well for this particular staff member? So as a leader, you need to know who you're talking to and what they like, or like if this is a person that's embarrassed by you giving them verbal reward, like recognizing them in a meeting, then that's not going to be beneficial for them. They're actually going to stop doing things, so you'll stop doing that. But if that's somebody who is hungry for recognition of their hard work, then you will be bringing that person's name up in a meeting, because that will help reinforce their positive attitude. We need to make sure that others on the department recognize where people are working towards leadership and being recognized, and then others who are actually following those particular leaders. Do other departments like lab and x-ray and cath lab, you know, how do they recognize and trust based on positions? Physicians, their recognition of this trust component for nursing has been a long, drawn-out process, but it is finally being seen out in the practice world. We are beginning to see more and more collaboration rather than dictation on care. Many of the newer physicians who have had their education within the last 10 years have shown significant respect and actually have stated that, yes, you're the one that's with the patient 24/7. Why wouldn't you be the one that tells me what's going on? Because you're the one that knows. So that recognition is significant, and that we now have a shift, a paradigm shift in our world, in our healthcare world. So now we have to recognize, if we are trying to have someone be a leader, we have to make sure that they have the appropriate tools and equipment that they need to be a leader. And then that leader needs to make sure that the people that are working for them have the tools that they need to get their job done for the day. So we're going to talk about quite a few things, okay? One of those is, like I said, that deployment of self. This is where you have to actually put yourself out there and take a risk. You are committing yourself to accepting a challenge, and you are going to proceed and persist about this because you know it's the right thing to do. This is where people look forward to seeing you fail or make mistakes, which means that this is the worst problem a leader is going to face, but it is something that you will face early on before your success. You don't know that you've succeeded until you have met some failures. I'm not saying not try these, but I am saying that sometimes you win a battle or two, but you have to withdraw sometimes, and you have to choose and pick which ones you want to fight for, so that you actually win the war and eventually win everything. And I know that's kind of cliche, but it really kind of puts out there, yes, I need to fight for the patient's right to refuse treatment or to refuse diagnostics and x-rays. Well, at one time, we used to not do that. Patients were actually kind of intimidated into, the doctor wants this, sign the paper. And they had no clue what they were signing and what they were going to get. Now, they are very well educated. There's actually laws that require the physician to communicate with the patient about several components before any consent form is signed. And that came from nursing leadership and advocating for patients. Emotional intelligence is now being measured for people in healthcare. There are, like I do know that here in the Valley, Abrazo Healthcare, I'm not sure about Banner, but I do know Abrazo Healthcare does an emotional intelligence evaluation. So once they accept your application and they want to review you, they will actually send you a link to an evaluation tool, and they want you to, share a little bit about yourself. Would you, you're given a scenario, would you consider this to be good, bad, or somewhere in the middle? And how far in the middle? And then what might be a decision or what might be a feeling that you have about a certain circumstance or a certain situation? And then they take that and it's analyzed, and then they make a determination on what your emotional intelligence is. These things are things that can help the person recognize what their emotions are and actually help take them and use them to positive rather than having a barrier, okay? So self-awareness, self-accuracy, and then, of course, self-confidence can be built with utilizing emotional intelligence. We can also look at self-management, control, trustworthiness. How conscientious is this person? Are they adaptable or not? Are they achievement-driven? Can they be initiative, or are they someone who needs to have an initiative done, and then they are a solid follower? We also have some social awareness, such as empathy, service, orientation, and dedication to the service. Relationships, such as how do you develop others, how do you influence others, your communication, your conflict management, and your leadership style. All of those things are part of what the emotional intelligence tool evaluates, and then that is then considered for a particular position that you've applied for. And so these positions are evaluated based on what's going on and what's needed, and then they kind of put these things together. So empowerment and mindfulness is part of the EI components. So there's the stage 1 and 2, which is the self-mindfulness, self-empowerment, and then the others, which is the social awareness of mindfulness, and the relationship management of empowerment. So I recommend that you look a little bit more into these 4 components, the 4 areas of emotional intelligence. There actually is a YouTube video on EQ, and if you are interested in taking the emotional intelligence quiz, this link right here will take you there to a free quiz. I will tell you it's kind of interesting to see what your strengths are, and you'll be not surprised by some and then very surprised by others. So I actually encourage you to go and complete that. Applications of the leadership standard. Leadership is where we are nurses, and we will be a leader by upholding the nursing social policy and the scope of standards of our professional practice. RNs are to advance nursing autonomy and accountability through the use of evidence-based practice. You are to demonstrate leadership by seeking competency-based education and continuing and ongoing training and education. Nurses in formal leadership roles have to ensure that structures and processes exist that actually support the registered nurse in the professional practice settings. So your leaders need to make sure that you have what you need to be successful so that you can be successful with your patients and make an impact to the good. So we're not going to do the activity. I will say that you may do that in your class. There is a future of nursing, the nurse leader in the boardroom. This is a very interesting website. I do know that here in Phoenix, I think there are 3 RNs that are on any kind of healthcare board. And we really need to have more nurses involved because nurses are the bulk of what takes care of the bulk of the patients. We would have the most information, and that would also give us an area where we could actually impact the best advocacy for our patients. There are essentials. The American Association College of Nursing has the essentials of baccalaureate that are required that go into the program like you're in right now. And your program was developed with these essentials in mind. Well, Essentials 2 is all about organizational systems leadership so that we can have better quality and we have better systems thinking. Now, doesn't that kind of sound like one of your Nurse of the Future competencies? Quality and systems, communication and systems-based thinking. I think so. Essential 6 talks about healthcare policy for advocacy. This is where you as a professional take on a key leadership role to advocate for your patient, which we just discussed that in the advocacy component of this. Essential 7 is about our interprofessional collaboration, where we have interdisciplinary collaboration working for the betterment of patients and overall population healthcare outcomes. GCU's mission and vision might be something that can help you see how our personal vision will help you see how our nursing vision is actually being worked towards based on what was our vision, now how we're getting there, and what outcomes we're expecting. Make sure that you understand the different types of leadership styles. There's a servant leadership. This is someone who's very supportive of those around them for their personal and professional growth. They are actually empowering others to increase their nursing leadership. They encourage collaboration, satisfaction, and retention. It's very important that, once you dedicate that much time to someone, you want them to then dedicate some of their time to others. So this needs to be pass it on kind of thing. Authentic leaders are leaders who are actually true to themselves, and they do what they say and they say what they do, and you know that they will act accordingly. There will be no surprises when you talk with them. A quantum leadership is where somebody has identified common goals And they've actually sought each other out to build specific opportunities to empower a specific team and or an organization in making decisions, okay? So that would be like, okay, so the hospital's organization CEO has a team of educators that is in the professional practice department at Banner Hospital, all Banner hospitals. And each facility has a director of professional practice. And there is one lead director of professional practice that they all work together towards the education of the people who work for Banner. And so that would be a quantum leadership example. Now, transformational leadership is a little bit like servant leadership in that it inspires others, but it's more towards inspiring them to change, to meet forward-moving items, to help adjust perceptions, to help create something that will motivate others to work towards a common goal. So it's actually a common goal like quantum, but it's got a mixture of servant leadership, but there's a purpose behind it, not just the altruistic piece like servant leadership. There's a reason behind why they want you to work towards this common goal. Usually it's for the betterment of the unit or the hospital or the community, those kinds of things. Pat Benner is the #1 person that will help create our healthcare of the future. She actually was on the Institute of Medicine panel that did the reports on nursing and the nursing leading change. If you're not a member of the Institute of Health, I actually recommend it. It's free, well worth it. And they actually have something called an open school. So it might be something that you want to consider. We're going to skip the activity. Please remember that you are only allowed to work within a specific scope of practice. The scope of practice is defined as the depth and breadth in which an individual registered nurse engages in the total scope of nursing practice, where they are dependent on their education, their expense, their role, and the population that they are serving. Okay? So nursing leadership competencies that actually fall within that scope of practice would be delegation, right? Delegation. Unlicensed personnel, you're going to be delegating tasks and roles. Make sure that you can do so appropriately. You need to know what their abilities are. Advocate. You're going to advocate not just for your patients, but also support and recommend for others on your area, your peers and your colleagues. You're going to do critical thinking. I think you've heard quite a bit about that, where you actually have purposeful, informed thinking, where you actually are looking at what the outcome you want it to be, and that's what you're focused on, and that's what you're reaching for. That is critical thinking. Clinical judgment. This is how you make the way you make your decisions. Okay? How did you get to your conclusion? It's the process of going through and making the right choice so that we go the right direction. Accountability is where you are actually responsible or answerable for something that you did or didn't do, because sometimes that's it as well. And then the other piece is lifelong learning. Nursing is always lifelong learning. Nursing is nothing like it was over 30 years ago when I first started. We did not have anywhere near the technology that there is out there now. So it has changed drastically. And I actually think that in another 30 years, when it's your turn to be in this role, that it's going to look very different than it does right now for you as well. Delegation, remember, that's all about transferring a responsibility for a duty. You're giving someone a task, but you have to make sure that they're doing it safely and that they know how to do that. The National Council of State Board of Nursing actually has a component on that, as well as the Arizona State Board of Nursing. So you have to know that if that's in your State Board Practice Act, then you need to understand it because it regulates what you can and cannot do. So there are 5 rights of delegation: right task, right circumstance, right person, right directive, communication, and right supervision. Kind of sounds like the 5 rights of medication administration, doesn't it? But they're very important. The right task is, if they do not have the knowledge, then they can't do that task, all right? It's not safe for them to do that. And you can't just say, oh, go give this, and expect a CNA to go and give a med that you gave them. That's totally out of the realm of their knowledge base. The right circumstance, because we're looking at what they can and can't do and what kind of position they can or cannot fulfill. If you need another RN, a licensed, an unlicensed personnel will not fulfill that need. They will not fulfill that need. So safety is compromised, okay? So the appropriate planning and execution of any kind of delegated task matters. You have to pick the right person who has the education to do that. That's who needs to be delegated that task. So we are ethically and morally responsible for the information that we disseminate and take in. If we mislearn any information, it can be potentially harmful to people and creatures. Increased work demands actually threaten our breakdowns in communication, which causes difficulty in appropriate delegation, resulting in errors. Ineffective delegation can result, again, in inappropriate or missed care for outcomes that are poor. Right supervision, okay? So once you have delegated to the right person, you need to understand that they know how to do it. Were they competency checked off on a skills checklist when they were hired? Was it accurately monitored and checked off, or did they just get somebody to check them off? Those are the things that you need to look at. The case studies, again, are going to be something that you're going to do in your classes. The Safety and Quality Act, you have to make sure that the delegation that we make meets the patient's needs, that it fits in with the complexity of the work. It is something that is within that person's domain or ability and knowledge, and that they actually have the time to get it done. Do not rush people through things because of a lack of time on your own part. We need to know that if we need time to do what we need, they also need to have enough notification so that they can get their tasks accomplished appropriately as well. So that actually gets the leadership component completed. The last piece of this is about professionalism. Professionalism, you can't actually have advocacy and leadership without having professionalism. Okay. So, well, this one's going to be problematic as well, so we'll just go this way. All right, so professionalism, the nurse of the future competency, the nurse of our future is able to demonstrate accountability for the delivery of standard-based nursing care that is consistent with moral, altruistic, legal, ethical, regulatory, and humanistic principles. Now, R419-403 regarding unprofessional conduct is actually within the scope and standards of practice of the Arizona Board of Nursing as well as the American Nurses Association. So there are a standard of professional practice which regards your ADPI, right, your nursing process. Then there's the standards of professional performance. Are you competent to be at that level, and is your behavior competent and professional enough to do the role? Are you behaving appropriately? Those types of things. Now, communication, leadership, collaboration, all of those things go together to make you a professional. So advocacy, we've already spoken about advocacy just a little bit, but make sure that you are actually navigating the patient through what the patient wants and needs, but yet you give them the education they want and need to be able to make appropriate decisions, well-informed decisions, especially about their health and how to make the best outcome. This is a quest where we want to actually make the systems and our policies the best effective we can. The three overarching goals are that it's patient-centered, that we increase patient involvement, and that we actually make this a safer system altogether. So your advocacy project is all about something that you would like to have changed. Okay? Sorry. So we do have some states that made changes based on the American Affordable Care Act. One of the things is that, you know, it doesn't have to hurt, but some people feel like it does hurt. And that's, again, as we discussed in the earlier presentation on advocacy and leadership, that we need to make sure that resources are divvied up equally and rightfully and justly so, and that everybody has the right to health care. So we have to look at that, and there's a link there at the yahoo.com regarding inequality for won't hurt bit. It won't hurt for a bit. So there's actually malpractice issues that have to be discussed. There are some ethical considerations to the IOM competencies for each of the 9 provisions of the Code of Ethics that they have, which we're going to get into in more detail. You do need to ensure that you have read and understand the ANA's social policy statement. And then we actually need to then combine this policy statement and the Code of Ethics with the IOM's in-depth work report on our healthcare systems so that we can quality improve and then use those core competencies to actually improve the students and our future nurses and helping them be creative. So we actually have a call for action for Arizona nurses, and it is a 3-step call to action. It is in place. The call to action is in place. We've actually had about 1.5 years, almost 2 years worth, but we are always seeking more people. So if you have any kind of desire where you want to impact the nursing in the state of Arizona for the future, this is the one to get in on, because this one is the one that's in collaboration with the Board of Nursing. So if you really want to have a say, I recommend that you maybe go to the website and take a look at it and think about that. So ethical studies we're going to talk about. We also have to be able to recognize that evaluation and feedback from our peers to us and from us to our peers is extremely important, which is why when you do your advocacy presentation, there is a component where feedback is provided to the presenter on, I saw some spelling errors, maybe if you change the background to a darker blue or a little bit different color font, we could see it better, those kinds of things. So this is not criticism to be hurtful. It is criticism to help stretch and grow this person so that they can be as good as they can be, and their presentation is as professional as it can be. Okay? So make sure that you take responsibility for what you've done and the words you've used. Take time to reflect on what was said in the thing and not blame others for what's happening. If there is an issue about some kind of perceived behavior, the best thing to do is ask for clarification. There are circumstances where people are considered late, when in actuality they're not late. They show up early to try to help out. So you need to do not ever assume things. It's really not in the best interest of you, your peers, your colleagues, or your patients. Then also, remember, there is always a little bit of truth in every single criticism, okay? Please stay focused on what you can learn from the situation. Say that to yourself. What can I learn from this? Okay? And that actually concludes our presentation on advocacy, professionalism, and leadership. I hope that you have enjoyed the presentation. It's for Nursing 421, fall of 2015. This is Professor Land, and doing the first 3 competencies of the Nurse of the Future competencies. Thank you.